the upfront setting only, because this is a real world setting from the Western data. These all studies are recent studies published in 2018 to 2020, and we can see that out of 100 patients in the various study who have been treated with the first line treatment, only 35 to 39% of the patients receive further second line of treatment, and from second to third line, if we compare to the first line, only 10 to 15% of the patients go for the subsequent third line of treatment. So we can see that there is high rate of attrition, and the patients who are receiving further line of treatment are very drastically reducing. So talking about the pathology, we know that the treatment for considering treatment, we should know whether it is a urothelial cancer or not, and mostly of them are urothelial cancer. They may have some variants of them, are some variants are also there, which should also be kept in mind. Like there can be squamous cell differentiation, there can be glandular differentiation can be there, or there can be some other macropapillary variant are there. Other thing, important thing is to know the PD-L1 status for considering the immunotherapy and judging the response of the immunotherapy. Although it is not required for the subsequent line of treatment after first line of therapy. NGS and PCR already have been highlighted by my dear friend Dr. Amit, how it is important for selecting the chemotherapy, not only metastatic but also neoadjuvant chemotherapy. And in metastatic setting, we are currently having indications approved drug if the patient is having FGFR 2 or 3 mutations, and whether the patient is having mutational HHR or not. So why it is important to know FGFR mutation? Because we know that FGFR alteration is present in around 15 to 20% of the advanced urothelial cancers, and out of this, mutated FGFR3 presents in around 37% of upper tract urinary cancer, compared to 23% in the all. So upper urinary tract having a much higher rate of FGFR3 mutation. And if we compare low grade versus high grade, then this mutated FGR is more common in the low grade urothelial cancers. How this mutations affect, these mutations or application lead to constitutive activation of the downstream pathway in the form of RAS-MAP, PIK3 AKT pathway, and they can lead to constitutive fossilization and further progression of the cell multiplication. So this slide has been discussed, previous slide have been discussed by Dr. Vinesh. And so before treating any bladder cancer, it is always important to know whether the patient is platinum eligible or ineligible, and if it is platinum eligible, whether the patient is candidate for cisplatin or not. So this again in the metastatic setting also plays very important. And apart from this, we can also classify the patient as having a good risk patient or poor risk or good risk patient. Good performance status, no visceral or bone disease, or normal alkaline phosphatase and electrolyte hydrogenase levels. This can help us to predict whether the patient is in good risk or is a poor risk patient. Again, defining platinum ineligibility has already been covered by Dr. Pooja, so I will not skip this slide. So, how do we select first line therapy in metastatic bladder cancer? So, we know that available chemotherapy options to us, and this has been highlighted in this table. You can see if we are giving single agent cisplatin, then the response rate is just 12% with the OS of 8%. If we give a combination of chemotherapy in the form of MVAC and high dose MVAC, we can see the response rate is in tune to 50 to 64%. But again, we know that these drugs are not easy to administer. Patients are having too much of side effects, and but the PFS and OS are best PFS and OS are achieved in this regime. The commonly used regime is gemcitabine with cisplatin, which the response rate of 44 to 50% and PFS of 7 to 9 months and OS of 14 months. But if the patient is ineligible for cisplatin, if you are giving carboplatin, we can see at the top, at the bottom, that the response rate fall from 50% to 41%, PFS fall from 9 months to 6 months, and OS is fall from 14 months to 9 months. So we should always wisely choose our patient, and we should try to give cisplatin if a certain modification can be made with the certain interventions. So this is the NCCN guideline for cisplatin eligible and ineligible. Now, coming to the sequencing of the therapy, it is very important because we will see how this makes difference. So there are three approaches if you are treating unresectable locally advanced or metastatic urinary cancer. First one is wait and watch. Wait and watch means after giving first line of chemotherapy, we will just observe the patient and we will initiate the second line of therapy once the patient is having disease progression. Continuous maintenance is in the first line only we are giving chemotherapy combined with immunotherapy. Chemotherapy is given for fixed duration, fixed cycle, and if the patient is having some sort of response in form of CR, PR or stable disease, then chemotherapy is stopped, immunotherapy is continued, and once there is progression, then second line of treatment is initiated. In switch maintenance, only chemotherapy is given for fixed duration as the first line therapy. If there is CR, PR or disease is a stable disease, then we will stop chemotherapy and we will switch our therapy from chemotherapy to immunotherapy as a maintenance therapy, and we will give till the patient is having response or unacceptable toxicity, and on further progression we will give in subsequent line of second therapy. So by the three method we can see, although it is data is not mentioned, but we can see this is the parameters are drawn as per the available data that we are getting the best overall survival with the switch maintenance adopted regime. So this is the wait and watch approach. So in this, when first line platinum based chemotherapy was given, overall response rate was 40 to 50%, and disease control was 15 to 20%, but median OS was around 15%. So we can see that with this approach, what we can benefit is around median OS of around maximum of around 15%. If we are giving continuous maintenance, and then it has been tried in various trials. Dr. Avipnesh has already highlighted them, and we can see that outcome in the invaluable trial when atezolizumab was given, there was no significant benefit in the overall survival. In keynote 361, again the combination of in the first line setting, then again we can see with this the median PFS with the enfortumab was around 5.5 months compared to 3.7 months. Although these drugs need to have as these are the new drugs and we are not having hands-on experience with them and are having a slightly different toxicity profile in the form of neuropathy, pruritus, hyperglycemia. So these drugs and not with that much available data, these drugs need further another options which have been tried is in the form of phase 3 trial, third trial, in which adafatinib was compared with the other immunotherapy or other investigator choice treatment in the form of docetaxel or vinflunine, and the result of this is not available. Another phase 1, phase 2 knowledge trial in which adafatinib with satelimab was given in the patient who have been previously treated with metastatic cancer, and this trial has been recently results of the trial has been recently published of the phase 2 trial in the as a form of abstract in the ESCOT, and it has shown that with the combination of adafatinib with satelimab versus adafatinib alone, the overall response rate has increased by around 20%, with the PFS also gained around 10 months in the combination of compared to the adafatinib alone. So this is again the Egyptian guideline which summarizes the present data level in the form of the patient who have been already treated with chemotherapy or the patient who have received checkpoint inhibitor. For the patient who have been treated with platinum or chemotherapy, we have option of pembrolizumab or we can give other immunotherapy like nivolumab, erlotinib, adafatinib, and the patient who have already received post immunotherapy, then they can be given with enfortumab or other chemotherapy options. So I think with this I will conclude my talk, and thank you.
Thank you, Dr. Anuj. So that was again